Professor Fu, can we start?
Yes. Let's start right now. Yeah. Hello.
Hello.
Hi. We will start right now. I will introduce Professor Ikeda. Professor Ikeda is the chairman and the professor, Department of Psychiatry, Osaka University, since 2016. Professor Ikeda studied anthropology in Tokyo University because he was very interesting about human beings. So he decided to be a doctor. He studied medicine at Osaka University. After Tokyo University, he received neuropsychology, neuropathology, and OH psychiatry training in Psychiatry Research Institute of Tokyo, Ohio Institute for Aging, Brain, and Cognitive Disorder, University of Cambridge, and Inhi University School of Medicine. He was a chairperson and a professor, Department of Neuropsychiatry, Faculty of Life Science, Kumamoto University from 2007 to 2016 and moved to Osaka University. With his background neuropsychiatry, neuropsychology, and OH psychiatry, his research covers a wide area in clinical neuropsychiatry. He served as a board member of many academic societies, such as Neuropsychology Association of Japan, president since 2019, Japan Society of Higher Brain Dysfunction, Japanese Society of Dementia Research, Japanese Psychogeriatric Society, president since 2018, Japanese Society of Psychiatry and Neurology, ASAD, and the International Psychogeriatric Association, IPA, president since 2021. Professor Ikeda is an old friend of Taiwan. He had been visit Taiwan for many times. He's very kind to Taiwan. Let's welcome Professor Ikeda.
Can you hear me,
Yes?
Dr. Hu?
Yeah,
Oh,
yeah.
hello everyone, and thank you for your kind invitation, Dr. Fu and Dr. Huan and the organizers. I'm very honored to give my video talk in this meeting. Today, I chose a topic, psychosis in prodromal stage of dementia. So I'm a little bit anxious about it is interesting topic for neurologist or other specialist, but I'm a psychiatrist. So I think like a mild cognitive impairment, mild psychiatric impairment is also the key condition, one of the key condition of prodromal stage of dementia. So I would like to discuss with you in Q&A session after my video talk. Thank you.
Yeah, thank you, Professor Ikeda. His talk will be presented as a video.
I'm honored to have the opportunity to give my talk in this international medical conference. I choose the psychosis as today's topic. With increasing knowledge on the molecular biology of the pathogenesis, development of biomarkers and disease-modified drugs, mild cognitive impairment, MCI, due to neurodegenerative diseases has become main target of investigations and interventions. However, neuropsychiatric symptoms are also very important target for the diagnosis and interventions in prodromal and early stage of dementia. Psychotic symptoms, which consists of hallucinations and delusions, are among the most clinically relevant neuropsychiatric symptoms and are associated with hospitalization or institutionalization, cognitive and functional impairment, accelerated cognitive decline, and mortality, as well as caregiver distress. The first onset of psychosis in late life is more common than previously assumed. In this talk,
Dr. Warren, if
I'd
it is
like
difficult to
introduce
use video,
late life
I
psychosis
would like to
from
talk directly.
psychiatric viewpoints. Especially, I try to explain the international consensus definition of very late onset schizophrenia-like psychosis. Secondly, I would like to discuss about the possibility that late onset psychosis occurs as a prodromal symptom in neurodegenerative dementia. Actually, substantial evidence suggests that psychosis can emerge during the prodromal or MCI phase of the neurodegenerative disease continuum. In the latter half, I describe the main features of psychosis in Alzheimer's disease and dementia with Lewy bodies, and their associations with disease stage and severity. I also show you our prodromal dementia cases, whose initial symptoms were psychosis. Psychosis, most simply defined by the presence of hallucinations and delusions, is relatively common in late life. Neuropsychiatric etiologies of late life psychosis include chronic conditions such as early onset schizophrenia, late onset schizophrenia, delusional disorders, psychosis associated with various dementias, and affective disorders with psychotic features. Historically, the literature on late onset psychosis dates back over a century. There have been huge controversies about differences between these late onset psychosis and early onset schizophrenia. As you can see, various terms have been used to designate primary late onset psychosis. Despite the varying landscape of terminology, these phenomena present a rather consistent clinical picture. In the 1940s, Manfred Breuer coined the term late onset schizophrenia to describe persons whose symptoms first manifested after age 40 40. He observed that approximately 15% of schizophrenia patients manifested onset of symptoms after age 40. Martin Roth employed the term late paraphrenia to describe a well-organized system of paranoid delusions with onset after 45, with or without hallucinations existing, in the setting of well-preserved personality and affective response. Howard et al. Aimed to harmonize research by defining late-onset schizophrenias as onset after 40 years of age, and very late-onset schizophrenia like psychosis, VLO-SLP, as onset after 60 years, with the latter term reflecting enduring uncertainty in the nosological status of the patient group. An international expert consensus referred to psychosis with an onset after 60 years of age as very late onset schizophrenia-like psychosis, VLO-SLP. There is a female predominance in VLO-SLP. Second, sensory impairment and social isolation are common risk factors. VLO-SLP is characterized by positive symptoms such as delusions and multimodal hallucinations. Specifically, paranoid delusions and partition delusions, in which people, animals, materials, or radiation are believed to be capable of passing through a physical structure, like a wall or a ceiling, that would normally constitute an impassable barrier, are highly prominent. On the other hand, formal thought disorder is usually absent. Furthermore, there are fewer negative symptoms, such as affective flattening. Less familiar aggregation of schizophrenia suggests a lower genetic risk factor for VLO-SLP. Based on the cross-sectional studies, organic signs such as profound cognitive impairments and neuroimaging abnormalities are in the exclusion criteria. An important and ongoing issue is the relationship between the emergence of psychotic symptoms in later life and the risk of incident cognitive decline and dementia. As you can see, several epidemiological studies have found that VLO-SLP is related to an increased risk of dementia. Moreover, it is well known that considerable hallucinations and delusions are developed even in the MCI stage. This cohort study included 12,000 participants from the Alzheimer's disease centers across USA who are 60 years and older and had normal cognition at baseline. Participants completed the neuropsychiatric inventory questionnaire at baseline and are followed up almost annually for incident dementia. Median follow-up is 4.7 years. The various neuropsychiatric symptoms showed independent yet differential associations with incident dementia. although psychotic symptoms were rarely endorsed by the participants, they predicted much higher risk of dementia than affective symptoms or agitation symptoms. To study the relationship between neurodegenerative diseases and late-onset psychosis, whose onset occurred at 65 years and older, Nagao et al. Pathologically examined 11 patients with late-onset psychosis and 71 age-matched normal controls. They excluded cases with simple delusions, such as delusions of theft, which frequently develop in Alzheimer's disease. In late-onset schizophrenia and delusional disorders patients, the frequencies of Lewy body disease and alveophilic grain disease pathology was 36.4% respectively, and alveophilic grain disease was significantly more frequent in these patients than in normal controls. Given these findings, late-onset psychosis patients may have heterogeneous pathological backgrounds. Let's move on to the next topic. I would like to discuss the features of psychosis in dementia, especially Alzheimer's disease and dementia with Lewy bodies, and their associations with disease stage. Delusions are most frequent in DLB among major 4 types of dementia. The most remarkable findings of this study was that the severity of dementia rated by CDR was not always associated with worsening delusions in DLB. The patients with DLB had profound delusions, even in the very mild dementia stage, and the degree of BPSD was unchanged until the moderate dementia stage. On the other hand, the frequency of delusion of Alzheimer's disease was related to dementia stage. On the other hand, the frequency of delusions was related to dementia stage in the patients with Alzheimer's disease. Prevalence of delusions in Alzheimer's disease was between 35% and 45%. Prevalence of hallucinations in Alzheimer's disease was relatively low and below 20%. The delusions seen in Alzheimer's disease have distinguishing characteristics from those in schizophrenia. The delusions are typically simple, non-bizarre, and paranoid. Individuals with delusions might represent a heterogeneous group. Persecutory delusions, such as delusions of theft, are the most common and occur earlier in the Alzheimer's disease course, followed by misidentification delusions, such as TV sign and phantom border, which are associated with advanced dementia and greater cognitive impairment. This table showed types of delusions of our 53 consecutive Alzheimer's disease patients with delusions. 75% had delusions of theft. 30% had misidentification delusions. Someone is in the house. And 27% had delusions of suspicion. Delusions, especially delusions of theft, are significant problems in caregivers of Alzheimer's disease. Primary caregivers are frequently involved in the patient's delusions as a target. The patients complained to neighbors or family members that principal caregivers, their husband or wives, were stealing their valuables. Female gender and higher cognitive levels were associated with this type of delusion. To investigate the neural substrate of the delusion of theft in patients with Alzheimer's disease, 9 Alzheimer's disease patients with only one type of delusions of theft, and 9 age cognitive function matched Alzheimer's disease patients without any type of delusions were selected out of 334 consecutive outpatients database. All subjects underwent HM-PAO SPECT scanning, and SPECT images were analyzed by SPM. Alzheimer's disease patients with delusions of theft showed significant hypoperfusion in the right medial posterior parietal region compared to patients without delusions. Our data suggests that deficit of visual imagery at episodic memory retrieval or lack of awareness of illness related to right parietal dysfunction might play a role in producing the delusion of theft. This is a 12-week open-label prospective structured trial conducted to evaluate the efficacy of risperidone in the treatment of delusions of theft in 16 outpatients with Alzheimer's disease. Scores for items concerning delusions of theft on the NPI dropped most significantly during and after treatment with risperidone. Before treatment, caregivers show high burden level. After treatment, the ZPI total scores for these caregivers decreased significantly. In this study, delusion of theft in patients with Alzheimer's disease were eliminated or reduced with risperidone without decline of cognitive function or serious adverse effect. Biomarkers for Alzheimer's disease have significantly advanced the field in several ways and hold tremendous promise for diagnosis, staging pathology, and measuring treatment response. The first biomarkers to change are CSF and plasma A-beta 42 and A-beta 40 ratio. This is shortly followed by CSF and plasma tau increase. As a neural response to the amyloid changes. Shortly thereafter, amyloid PET turns positive. A few years later, tau PET turns positive, but it is still in preclinical or prodromal stage of Alzheimer's disease. As I mentioned above, VLO-SLP is a disease entity supposed to be a primary psychotic disorder. Some are probably secondary psychosis with insidious neurodegeneration. Advanced biomarkers such as amyloid PET and CSF may contribute to the detection of secondary psychosis with Alzheimer's disease from clinically diagnosed VLO-SLP. Now I would like to show you our prodromal Alzheimer's disease case with psychosis. She was a left-handed high school graduate. She lived with her husband. She had no psychiatric or neurological family history. 4 months before her visit, she got a persecutory delusion, wherein her neighbors entered her house during her absence and followed her everywhere. She harbored the idea of finding something in an unexpected place and thinking that someone had moved it during her absence. She also began to become sensitive to lights in her daily life and said that someone cast flashes at her. Because her delusional ideas disrupted her daily life, she received clothiazepam for her anxiety from her primary doctor before her first referral to our hospital, where she was hospitalized under cross-examination for diagnosis and treatment. Neurological examination, blood test, and electroencephalography findings were normal. The MMSE score was 28, 2 points lost in the track of serial sevens, and logical memory in the Wechsler memory scale revised was 11 in immediate recall and 1 point in delayed recall. ADAS-JCOG did not reveal any cognitive impairments. Her MRI showed almost no visually related cerebral atrophy, no cerebrovascular lesions, and no white matter T2 hyperintensities. IMP SPECT and cardiac MIBG scintigraphy showed no specific abnormalities. Based on the above results, we diagnosed this patient as VLO-SLP. We judged that the mild amnesia found in this case was attributed to her psychosis and anxiety at that time. In the CSF testing, phosphorylated tau and total tau were abnormally elevated. Those results were reported within 4 weeks after the discharge. ApoE genotyping showed Y4 and Y3. All these results were suggestive of Alzheimer's disease pathology. 1 year later, CIT-SPECT suggested negative result. However, amyloid PET was positive. Based on this evidence, she received a diagnosis of Alzheimer's disease pathology. She gradually developed apparent recent memory impairments in her daily life, and finally was incapable of shopping and cooking by herself 2 years after her first visit. We finally diagnosed her with Alzheimer's disease dementia and started rivastigmine as treatment for her cognitive deterioration. On the other hand, her psychosis and anxiety had diminished compared to her first visit, and she just repeatedly reported that there were unfamiliar things at home. However, 2 years after her first visit, she began to present a mild delusion of theft. This case suggests that some clinically diagnosed VLO-SLP cases may be a prodromal Alzheimer's disease. Let's move on to psychosis in DLB. This slide shows the distribution of Lewy bodies in the Osaka's first case in 1976. As you can see, Lewy bodies are widely distributed in the substantia nigra, locus cereus, dorsal motor nucleus of the bugs, nucleus basiaris, hypothalamus, and cerebral cortex. Compared to brainstem Lewy bodies, those in the cortex are less eosinophilic and may lack a definite core. It is a reason why anyone could not recognize Lewy bodies in the cortex until Professor Osaka found out them in the dementia patients with severe psychotic symptoms. Actually, Professor Osaka said he examined her brain very carefully because her psychosis was so severe. The DLB Consortium has refined its recommendations about the clinical and pathologic diagnosis of DLB in 2017, updating the previous report. Visual hallucinations are the most frequent psychotic symptoms in DLB and serve as one of the core diagnostic features. Systematized delusions and hallucinations in other modalities occur less frequently than to visual hallucination, but are not uncommon, and are thus in supportive diagnostic features. If the polysomnography PSG shows REM sleep without atonia in a person with dementia and a history of RBD, there is a more than 90% likelihood of alpha-synucleinopathy, sufficient to justify a probable DLB diagnosis, even in the absence of any other core feature or biomarker. MIBG myocardial scintigraphy might detect early disturbance of the sympathetic nervous system in DLB and provide useful diagnostic information to discriminate DLB from Alzheimer's disease. MIBG myocardial scintigraphy is now indicative biomarker, as well as dopamine transporter imaging and polysomnography. As you can see, MIBG scintigraphy and dopamine transporter imaging could distinguish DLB from Alzheimer's disease. The present study demonstrated that patients with DLB showed a higher severity of BPSD than patients with Alzheimer's disease. Among the individual symptoms of BPSD, delusions, hallucinations, anxiety, and sleep disturbances were significantly more severe in the DLB group than in the Alzheimer's disease group. As you know, approximately 70% to 80% of DLB patients are supposed to have visual hallucinations, seeing things, for example, their own children, deceased relatives, worms and insects, and small animals, which are not really there. The patients with DLB had profound hallucinations even in the very mild dementia stage. And the degree of hallucinations was unchanged. Until the moderate dementia stage. As I mentioned above, visual hallucination is one of 4 core features in newly revised diagnostic criteria. Patients rarely experience visual hallucinations while being observed by clinicians. Therefore, instruments to detect visual hallucinations or related symptoms directly from patients are needed. Pareidorias, which are complex visual illusions involving ambiguous forms that are perceived as meaningful objects, are analogous to visual hallucinations and have the potential to be surrogate indicators of visual hallucinations. In this study, my colleagues, Professor Mori, when he was working in the Tohoku University, explored the clinical utility of a newly developed instrument for evoking pareidoric illusions, the pareidoria test, in patients with DLB. As this graph shows, patients with DLB produced a much greater number of pareidoric illusions compared with those with Alzheimer's disease or controls. Now this pareidorias test frequently used as a screening of DLB among many countries. In contrast to Alzheimer's disease, which shows bilateral parieto-temporal dysfunction, DLB is associated with severe occipital hypoperfusion, as you know. In this study, we explore the neural substrate of visual hallucinations in DLB by investigating changes in regional cerebral blood flow and psychiatric symptoms before and after cholinesterase inhibitor, donepezil treatment. 20 subjects with DLB who showed severe visual hallucinations were treated with donepezil for a 12-week period. Hallucination attenuated on therapy, while occipital regional CBF focally increased, suggesting that functional visual association cortex deficits may cause visual hallucinations in patients with DLB. Recently, we investigated the clinical feature of auditory hallucinations and the possible mechanisms by which they arise in patients with DLB. Of the 124 DLB patients, 35.5% had auditory hallucinations and 60.5% had visual hallucinations. The majority of patients, more than 90% with auditory hallucinations, also had visual hallucinations. Auditory hallucinations consisted mostly of human voices, and 90% of patients described them as like hearing a soundtrack of the scene. Approximately 60% of patients with DLB have delusions. More than 50% of these patients develop delusion in the mild stage, CDR 0.5. Delusional misidentification syndromes, such as Capgras syndrome and phantom border delusion, were most frequent. However, there have been some reports on DLB patients with unusual delusions, such as Othello syndrome, delusional parasitosis, and delusion of duplication. In particular, Othello syndrome, characterized by delusional beliefs of infidelity of partner, was known to be found in as much as 26% of DLB. Delusional jealousy, so-called Othello syndrome, is a psychotic syndrome characterized by a belief in the infidelity of one's supporters that reaches delusional intensity. Although delusional jealousy has been described in relation to organic psychosis, little is known concerning the actual role of delusional jealousy in dementia. The aim of this study was to investigate the clinical feature of delusional jealousy and possible mechanisms whereby delusional jealousy arises in patients with dementia. As you can see, the prevalence of delusional jealousy in patients who had DLB was significantly higher than that in patients with Alzheimer's disease and vascular dementia. There were no significant differences between patients with and without delusional jealousy in regard to gender, age, educational attainment, presence of other persons living with the couple, and MMSE score. On the other hand, delusional jealousy was preceded by the onset of serious physical diseases in nearly half of the patients. In the present study, 44% patients had serious physical diseases before the onset of delusional jealousy. As a result, these patients became more dependent upon their supporters for daily living and activities. In contrast, all but one of the supporters were active and in good health. In addition, nearly half of the supporters in our study often spend time away from the home alone. Physical disorders of the patient and good health of the support could therefore contribute to the patient's feeling of inferiority with regard to the support. In dementia, delusional jealousy may develop more easily in patients who have DLB and those with coexisting serious physical disorders. I'd like to move on the psychosis in the prodromal stage of DLB. In 2020, McKeith and the prodromal DLB diagnostic study group, including me, proposed research criteria for the diagnosis of prodromal DLB, which included mild cognitive impairment, delirium onset, and psychiatric onset presentations. The key features of the psychiatric onset DLB is characterized by predominant psychiatric symptoms that typically correspond to late onset major depressive disorder or late onset psychosis, which may feature hallucinations in visual and in other modalities, and systematized delusion, including Capgras syndrome. Identification of psychiatric onset DLB may be assisted by use of indicative biomarkers such as MIBG, myocardial scintigraphy. Now I would like to show you our prodromal DLB case with psychosis. Erotomania, Ducré-Lambeau's syndrome, is a relatively rare disorder characterized by the delusion that a person is in love with a patient. The patient was an 83-year-old woman who lived alone. Mild cognitive impairment appeared at the age of 82 years. Soon after, she had the delusional conviction that her family doctor was in love with her. Her symptoms such as gradually progressive cognitive impairment, cognitive fluctuations, and Parkinsonisms indicated DLB. Brain MRI revealed mild diffuse cortical atrophy and mild bilateral hippocampal atrophy, compatible with her age. SPECT revealed mild hypoperfusion in the bilateral parietal lobe. MIBG, myocardial scintigraphy, was low. The aforementioned results indicated a probable diagnosis of DLB. Following the examinations, she was prescribed 3 mg of donepezil, the dose of which was gradually increased to 10 mg. She was simultaneously prescribed 25 mg of quetiapine at night. However, we soon discontinued quetiapine because of its adverse reactions, such as drowsiness. We then prescribed pronancelin 4 mg per day and continued it with extremely mild side effects. After 2 weeks, her attitude to the delusion beliefs began to change. She gradually lost passion for her family doctor. Based on our suggestion, she changed her family doctor and was discharged from our hospital. During follow-up for 1 year, she rarely talked about the previous doctor, who had been the subject of her delusion. She still lives alone, and her delusion has not recurred. Such cases suggest that delusions might be the initial symptoms in the prodromal stage of DLB. Recently, Utsumi et al. Analyzed the characteristic psychotic features of prodromal DLB in 21 subjects who developed severe psychotic symptoms without dementia around 62 years old and were diagnosed as DLB after the 9 years longitudinal observation period. They were then confirmed to have DLB through indicative and supportive biomarkers. The psychotic features included a wide variety of symptoms, but convergent to three principal categories: catatonia, delusion, hallucinations, and depression and/or mania. Catatonia was observed in 9 cases. 5 were delusional, hallucinatory, and 7 were manic and/or depressive. The frequencies of visual hallucinations, auditory hallucinations, delusions, and depression symptoms before DLB onset were 42.9%, 57.1%, 52.4%, and 100%, respectively. Elderly patients with psychiatric symptoms such as catatonia, delusional hallucination, manic and/or depressive features, and delirium without dementia could indicate symptomatic psychosis or a prodromal stage of any neurocognitive disorder, such as DLB. Finally, I would like to show you the different difficulty and complexity of pharmacological interventions for DLB. This slide shows you the possible interventions for hallucinations and delusions in patients with DLB. The interplay among cognitive, psychiatric, motor, and autonomic symptoms of DLB makes the management of these symptoms complex and challenging. Improved treatment for target symptoms may be associated with worsening of symptoms in other domains. However, at this moment, we are able to choose better intervention from several options if we could precisely assess the symptoms. If the psychotic symptoms are very severe and needed acute interventions, we should use antipsychotics such as quetiapine. If the psychotic symptoms are moderate, first choice might be the cholinesterase inhibitors to ameliorate attentional deficits and cognitive impairments. If there is the possibility that depression and/or anxiety induce the psychotic symptoms, first choice might be SSRIs. In the case that worsened Parkinsonisms induce anxiety and lead to psychotic symptoms, first choice might be paradoxically L-DOPA treatment. Anyway, further therapeutic strategies are needed to investigate. I'd like to summarize. Several conditions can present with psychotic symptoms in older patients. A detailed discussion of all possible causes is beyond the scope of this talk, but this table summarizes a major differential diagnosis. As I mentioned in this talk, characteristic of VLO-SLP, late onset psychosis that onset after 60 years, is more likely to that of psychosis of prodromal dementia than that of early or late onset schizophrenia. Prodromal Alzheimer's disease and dementia with Lewy bodies may take the form of VLO-SLP. Further studies on VLO-SLP with biomarkers are needed. Thank you for your kind attention.
Thank you, Professor Ikeda. Any question from the audience? We have one question from Dr. Cai Jiafen. Yeah. Dr. Cai say some studies suggested that treatment with SSRI may reduce progression of MCI with previous depression to dementia. How about using antipsychotic on the psychosis symptom in a prodromal or preclinical stage of neurodegenerative disorder? How about your suggestion?
Thank you. It's a very important question, I think. In my talk, there is still open question. Psychosis is a risk factor of dementia or symptom in prodromal stage of dementia. So if it is the risk factor, the ideal treatment of delusion and hallucination in before the prodromal stage, I mean the preclinical stage of dementia, it might be prevent or delay to develop MCI and dementia. So I'm very interested in about this point. Thank you very much.
Yeah. Thank you for the answer. I have another question.
Yes, please.
Because the patient with DOB, they are sensitive to neuroleptin, and they have high frequency of delusion. How do you treat them?
Yes, thank you. It is also very important clinical question, I think. And one motivation to investigate the delusion in prodromal stage of dementia, it is Lewy body disease. Because as Dr. Fu pointed out, DLB patients, even in the prodromal stage, it is very sensitive to many drugs, especially neuroleptics, antipsychotics, and antipsychotic drugs. So if very severe hallucination or delusions developed in the prodromal stage of DLB, we usually use a quetiapine. It is relatively safe. But before that, we carefully search the circumstances of the patient's life. So usually multidisciplinary team, psychologists and occupational therapists and physician visited their home. Usually the patients live alone. And for example, change the more bright light, or if possible, explain the patient's symptoms as a disease to their neighbors and relatives, like that. After improvement of their life circumstances, some delusions and hallucinations diminished or reduced. And if it is not effective enough, it is not enough. We use usually quetiapine or yes, mainly quetiapine. Thank you.
Yeah. Dr. Li Weiru, he asks, the psychosis might become more severe in DLB patients when taking dopaminergic medication. What is your suggestion for the use of dopaminergic medication in patients with DLB?
Yeah, thank you. Based on the findings from Parkinson's disease, initially I also very nervous to use the dopaminergic agents to DLB patients with Parkinsonism and psychosis. But L-DOPA is not always induce severe delusion. So I'm not so nervous to use anti-Parkinson's drugs to DLB patients with psychosis. Thank you.
Okay. I also read papers that dopaminergic medication not worse psychosis.
Yeah.
Okay.
That's true. Yeah.
Okay. Dr. Cai Jiafen asks, does acetylcholine esterase inhibitor (ACI) using reduce hallucination in DLB?
Yes, very effective, I think. So yes, for delusions, it is not so effective, but the patients only developed hallucinations, especially visual hallucinations. Maybe first line is choline esterase inhibitors, especially donepezil, approved in Japan to DLB.
Yes, Professor Ikeda have a clinical trial of donepezil of DLB
Yes.
published in Neurology. I forget the year. Maybe
maybe first one is 2014 in Annals of Neurology. That is a second phase trial. And the result is best in second phase. But the third phase is in the maybe 2015 or 16, I think. The result is only effective, restricted to the cognitive domain. Phase 2, it's quite effective in BPSD also.
Okay, thank you. Any other question? Yeah. Okay. Thank you, Professor Ikeda. If you have further question, maybe you can join SID meeting in September, and we can meet Professor Ikeda. Yeah. Thank you very much
Thank
join.
you.
Yeah.
Thank you very much.
Yeah. Thank you. Yeah.
See you soon in ASD.
Yeah. Okay. Bye-bye.
Bye-bye.